Now, the next speaker we're really pleased to have is Associate Professor CaraJane Millar. She's an Associate Professor and the Chair of Speech Pathology at Victorian University. She's highly experienced in a wide range of practice, in particular the delivery of service where there may have been some barriers or restrictions in resources or access, which we've certainly seen through the SPIDER project can be an issue for people with intellectual disability. So welcome, CaraJane, and thank you for being with us this afternoon.
Thank you very much. So thank you for that kind introduction. Before I get started, what's actually a culture in speech pathology is generally we type in the name of the traditional land on which that we are calling in from. And so I will just let you know that for myself, I am calling in from Ngunnawal country. So I'm here today from Canberra. I live in our nation's capital, but I do work in Victoria. So I'm very keen to hear the Senate inquiry into Qantas at the moment. So that's my interest completely. So, however, the country on which we meet at VU is the country of the Kulin Nation, who are the traditional owners of the land, and I pay my respect to their cultures and their elders past, present and future. And as we share our knowledge and practices within the university, and hopefully some of my knowledge and practices today with you all, I do hope that they're embedded in culture and respect. And I acknowledge that we're all meeting on different lands and places of age-old ceremony. You'll have to excuse me because the screen I'm reading off is just slightly away from the camera. So if I make a different eye contact, it's because I'm looking at a different place to my camera. Before we get going, I'm really keen to know what you want to know from a speech pathologist. If there's somebody you can ask that question, it's a course chair of a degree, hopefully. Hopefully I know some of those things. So I'm going to do a really quick run through, and some of these are from our professional association, but it'd be worth putting it in the chat right now, that burning question you want to know from a speech pathologist, other than how can we get more of you? We are very aware. I've just recently read the World Health Organization's insight into refugees and migrants, and we're very aware that it's 8.9 million skilled health worker shortage internationally at the moment. So I can't tell you how we can get any more speeches. We're trying to produce them as quickly as we can, but any other questions, I'm really keen to answer them. So what is a speech pathologist? Well, sometimes we're called speech therapists, sometimes we're called speech language pathologists, sometimes we're called speech language therapists. However, our preferred term in Australia is speech pathologist, and SLT is from England, or SLT is from New Zealand, SLP is from America. So those are the common terms that we go by, but in Australia, we're speech pathologists. It seems to be very slow clicking between the slides. Oh, there we go. All those pretty little animations. Okay. Great. So our primary role is in the assessment and diagnosis and treatment of communication and swallowing disorders. So some people, you may just know that we do swallowing if you come from a hospital background, or if you're in a community health, you may think we just do stuttering or basic speech sounds, but we do assessment, we do diagnosis, so that's the pathologist term, and we do treatment for communication and swallowing. I often say I'm only good from the chest up. That's all I know about. We use a evidence-based approach and a person-centered approach to our care when working with individuals, and we use a variety of models of service provision. We also provide a lot of education, case in point today, and we also do consultancy services. So we may be giving advice to, for adults with a disability, we may be giving advice to an SDA around how they can manage the behaviour supports as well as communication and swallowing supports in a home, for individuals in a home. We contribute to research and advocacy. So myself, I work a lot in research, and speech pathology has been raising its awareness of our advocacy, particularly for the cohorts we're speaking about today, is about having safe communication spaces and spaces where people who are non-verbal can communicate their daily care needs. Speech pathologists work in a wide variety of settings, including hospitals, education settings, homes and aged care facilities, private practices, non-government organisations, juvenile justice, mental health, community health, and we also work across the NDIS as well. Speech pathologists work with people who have difficulties communicating and swallowing and drinking, and helping them to swallow and drink safely. This can be due to developmental delays, brain injuries, disability, so brain injury as in car accidents, or a stroke, also disability, dementia, mental health, illness, hearing loss, as well as other concerns that affect speech, language, and swallowing. So what you want to know is when to refer to us. And so speech pathologists can assist with a wide range of difficulties across the lifespan, including speech, saying the way we say sound. So this is quite difficult. We want to know when you refer to us, just roughly what you're referring for in which of our range of practices so that it is appropriate for us. So speech is the way I say the sounds. For example, if I speak slurry and run all my words together, or if I say tat for cat or something like that, where I have the sounds incorrectly. We also help out with language. So understanding the information that is told to me and producing an appropriate question. So for example, you ask me what pet I have at home, and I reply with a dog rather than green, which is the wrong answer. Voice involving pitch, quality, or volume of voice. So many people will have, who have COPD, for example, will have issues with their voice, and we can help them with their voice, and professional voice users. Fluency, everybody has seen The King's Speech, and you know we do this, the movie. So it's got to do with stuttering and fluency of speech, as well as we also do pragmatics. So how to say, this is a big thing around adults with a disability. So pragmatics, so it's not appropriate to say no, go away when somebody knocks at your door if you weren't expecting them. How do you say that in another way that is socially appropriate? And literacy, we work on reading, spelling and writing. And then what we call dysphagia, which is swallowing and feeding without coughing and coughing. And then we also do augmentative and alternative communication. And this is when we would use other modes of communication, such as symbols or signing, non-verbal communication. If there are concerns about one of your patients on your caseload ability with any of these areas, just refer to a speech pathologist. because we believe that early identification is the key to success. So these are the areas we work in, and this is the age of the last span we work in, from 0 to palliative care to death. These are all the areas we see people, and all these people need to see a speech pathologist. If you want more information, the Speech Pathology Australia website has some really useful resources, including fact sheets, posters, brochures, and they can help. Speech Pathology Australia has just redone their website, and I can tell you it's painful to use the new website. I don't think anybody likes it, but it is there. And sometimes the best way to navigate those things is through maybe the Raising Children's Network or NDIS. That'll get you to the right page on Speech Pathology Australia's website. The next thing is, I was just checking that wasn't a question for me. This is because I'm a lecturer. You see, I have to read the chat as well. The next thing, when it gets there, beautiful. So talking about how to refer to a speech pathologist. When you refer to a speech pathologist, a written referral is generally desirable. You may ring and pass on information to us. That sometimes can get lost in translation. It's okay. It doesn't have to be a clinical diagnosis at all, just some kind of example for what you're referring the individual for. So, for example, the individual sounds are coming out wrong, e.g. they're saying tat for cat. You know, something like that is enough to get us started. We also accept self-referrals from patients, but as Reece said before, it's much better to have a connected care team around that and supporting the individual appropriately. So speech pathology assessment and therapy processes will be informed by the presentation of the patient. So you give us the information, but it also gets informed by the presentation of the patient. We are very objective in our assessment. We have standardized assessments. We have rules about our assessments. Like a psychologist, you need to be a qualified, certified practicing speech pathologist to assess and diagnose many things, and to access those standardized assessments, you need to prove your qualification is fitting to the level. So because of the impact on funding that diagnosis from a speech pathologist may have. So assessments impact, we include a comprehensive case and medical history. So as much of their medical history that we can have, that really helps and saves time, but we understand everybody's busy. We do standardized assessments, but we'll also do observations in how that practically gets used. And we also do instrumental assessments such as fees and video fluoros and endoscopes and those sorts of things as well. There's a here's a summary of it all. Here are the key points. Next one. Okay, therapy. So that's assessment. Now therapy. Therapy sessions are usually conducted in blocks. So we have evidence-based practice on what is the best therapy intervention for each of our conditions that we treat. So, for example, if an individual presents with a condition called apraxia, so a difficulty with their motor planning of their speech, best practice intervention is a period of 6 weeks, 12 sessions all up, 45-minute sessions at least twice a week. Whereas something like a speech sound disorder or a phonological processing, where you produce the sound in the wrong position in your mouth, that could be fortnightly therapy supported with home practice for a series of 6 weeks. So we usually do blocks and breaks so that an individual has time for their motor planning and their motor processing to catch up. Some speech pathologists may provide services via telehealth, and therapy is always informed by current evidence. And it may mean that it's a group therapy or it's a parent or carer training therapy. And they may be asked to do home practice as well with that therapy. I'm doing well with my animation. So waiting lists may apply for public and private services. I don't think we say may apply. I don't know anybody who gets in quickly. There are some non-cost treatments, but there's not a lot. So for you, you can do the Enhanced Primary Care Plan. And with the Enhanced Primary Care Plan, that does provide a part of the session. So I think it's about $51 or something a session, but just to give you an idea, I'm about $300 a session. So I'm very experienced, I'm expert in my field, but speech pathologists can be expensive, and you just want to be careful that we're not setting up our patients to think that this is going to cover all of the cost. But there are things such as university clinics, there are other community health supported clinics and the like that will be a zero cost, but they may have a larger waiting list. When providing patients with a referral to a speech pathologist, you can actually get some sheets off the Speech Pathology Australia website on what to expect and how to choose the right speech pathologist. But my advice to you would be you can do this on the website. Hopefully it's still there somewhere, and you can actually find the local speech pathologist for you, develop a relationship with them so that you have that joint up connected care model. Now, chronic disease management plans. We've spoken briefly about that, and there can be a rebate for speech pathology. There's currently no recommended fee schedules for speech pathologists, and the majority of speech pathologists do not bulk bill. But we can claim back some on Medicare. Patients should be informed that they will incur an out-of-pocket cost, and there are other funding rebates such as Medicare, FAXIA, NDIS, and private health funds. Most private health funds cover a majority of speech pathology. It's helpful to tell people maybe, or ask them to ask the speech pathologist the number of sessions that they recommend. Patients with chronic and complex needs typically require more than the 5 sessions of the NDIS. Here's a nice little handout. We have some community handouts that you can give to help parents with developmental needs for their children, but also to just saying once again that there are so many benefits to actually having a collaboration between GPs, nurses, allied health professionals across the primary healthcare sector. I have found it the most effective thing in my practice, and I hate to say it, but I've been a practicing speech pathologist for 20 years now. At the university, I just want to tell you that we start connections strong and early. So our students are there. They are practicing, here they are practicing in a simulation lab with some simulated patients. They do that week 2 of their 5-year speech pathology degree at VU. And here is one of the students, I think she's in the clinic uniform about week 2 of her placement at her studies at VU. Oh, over the questions.
Thanks, CaraJane. It's really good overview for speech therapy as such a vital service, especially with people with intellectual disability. No one's put anything in the chat. I was just, suppose from a general practice point of view, when we do the chronic disease management plans, one of the requirements is to have a number of health professionals involved. And so those 5 sessions often get split. We're trying to split those sessions to just to try to include another person. So a person with a chronic disease who only sees a speech pathologist may not qualify for that team care arrangement because they don't have the 2 other people in the team.
Yeah, it is very difficult. I'm not sure if you finished your question, but it is really difficult around that. So say, for example, you might be referring somebody that we believe all behaviour is communication.
Mm-hmm.
So if an individual with a complex communication needs or a complex disability as an adult does need to get a chronic disease management plan, usually the behaviour support practitioner will be the speech pathologist as well. So we often do that dual role because there is no behaviour support practitioner out there, and all behaviour is communication. So we often pick up that role as well. But my advice would be to refer to an organisation that has a really clear behaviour support practitioner role. And a social worker is always vital to support someone in their whole environment as well. So yes, it does make it hard because you get 5 sessions and you've got to have 3 people. It's not a lot. So often that is the case of where we will do the consultancy role. So it'll be an assessment and then it'll be consultancy for the other 2 sessions.
Yeah. And I also like your comments about that, the importance in communication between health practitioners, because I know certainly as a GP, to get good correspondence back or letters back from speech therapists or occupational therapists, it teaches me the language that you're using, and it actually educates me as a GP. I think in general practice, when you're out there for a long time, we educate ourselves by what the specialists write back to us and say, oh, this is what they do. And so that communication is really important moving forward, so we can actually target why we're sending people and what is actually the roles of our specialist colleagues.
Yeah, I have often said to my main referrers when I was working clinically before I was working academically that we just tell me, is it that they sound funny or they can't find the right word? That's enough to get me started on whether I'm going to be the appropriate person or what I prepare for this individual client. I don't need their whole case history. It's very helpful, but just some of those tips of, we often get the referral that just says referral for speech, and then they turn up and it's voice, and we've prepared all of this speech sound information, and it's actually for voice. Their voice breaks, and we understand that because you're meaning speech as in speech pathology, not speech as in speech sounds.
Yeah.
Yeah.
Can I ask as well, with the NDIS funding, because a lot of people would be funded through the NDIS, do you think that's helped communication, or have people sort of personally, from a general practice point of view, I probably find that I have someone who's seeing a speech therapist fortnightly or monthly, and I never hear a thing. And it's not, and so I'm not involved in that team. And I wonder, because that's a separate funding, because the funding is independent of me sending a referral. Yeah. Is that something that you would find?
Yeah, I should probably take my background off before I provide my opinion on the NDIS. However, this is my personal opinion, and I've had a few conversations with Minister Shorten about this. I actually think the NDIS is fantastic. I think it's a great program. Yes, it's got gaps, all that sort of stuff. But I know some of my clients, when they got their first package, I was like, it's justifying the fact that it has cost you $40,000 a year to live with your disability. you know, and trying to support you to stay out of the poverty line. So there is a huge amount of benefits to the NDIS. However, I think the issue you're talking about is poor communication from the individual professional, and that's not on. And that is a risk that we see in our profession, and we're very, very aware of it. That often happens is new grads see the dollar signs with the NDIS and they set up private practices, and they go after the financial remuneration around that, and they're not experienced enough in terms of how you would you communicate in a connected care model. So as a course chair, we strongly discourage our graduates from going straight into individual private practices, running their own private practices, because if you were working with me and a client on the NDIS, it's part of my practice that I would, as soon as you refer, I would send a copy of the report to you and my intervention plan, and we have to do an annual, with the NDIS, we have to do an annual plan and update the care providers. So you have the right to be getting an annual letter on the progress that the individual has been making at therapy.
Yeah, that would be wonderful. Now, I see Veronica's raised her hand, but we don't actually have ability to sort of switch off cameras. But if you wanted to put any questions, Veronica, into the chat, and I can ask them on your behalf.
Thanks, Veronica. It makes me realise somebody's listening.
I'd have to say, look, my son's got an intellectual disability and he's actually having speech therapy coming to our home, which has been wonderful. Just to get the volume of his voice up, because he's a very quiet little whisperer.
Yeah,
that's been
We're
a challenge
very
for us.
loud. When I worked at a hospital, they actually redesigned the hospital and put me in the old morgue because they figured that was the best place to put me because I was so loud.
That'd be next to the prosthetist, is it? Because they're generally down in the...
Yeah, that's exactly right.
prosthetic department in the morgue.
Or the birthing suite.
Yeah. All right. I'm just... So, Veronica, I'm waiting for you to put something in the chat there, Veronica, if that's possible, because we can't open you up. All right. So we haven't got any other questions. We are sort of coming... We've still got
yes, we do
few
have
minutes
one
left. Do we? Oh, here we go.
Yeah, about...
Can you... Yeah.
Two.
Here we go.
Okay.
There's two. So the first one's from Nicole. Can we please share some examples of realistic patient goals when accessing speech therapy? Are the goals usually developed by one person or their supporters, or are they developed in collaboration with health professionals? What a great question, Nicole.
Yeah, that's great. Thank you for the question, Nicole. Goals, ideally, as we know, should be developed with the individual. There are guidelines through the NDIS on the way that goals need to be written and functional, which actually doesn't speak to the medical model that we were all trained in. Those functional goals can be very, very broad and non-specific. So we were raised in the SMART goal era of specific, measurable, accurate, realistic, and time-bound. And so what will happen with a good intake worker is they will develop those goals with the health professional and with the individual. However, it doesn't always happen. That's a bit wishful thinking. So we also, on that annual report where the individual goes to get their funding renewed, the speech pathologist or the health professional will write their goals. So if you can get your hands on those annual reports and request a copy of one, then you'll actually be able to see the actual therapy-based goals in those annual reports that are a requirement. Some realistic goals. So some of the ones that I would do would be Ahmed wants to, at the end of 6 sessions of therapy, Ahmed will be able to request for his drink at the local cafe when the supported day program goes out every Tuesday. You know, so that would be a goal that we would work on for an adult with a disability, so that we could actually say, okay, this is part of his routine. He's self-selected from Aspect that he will go to the cafe on a Tuesday, but we want him to be able to request his drink and increase his independence in that way. Another realistic goal might be that I'm trying to think of a female name. Jenny will, when she goes swimming every second Saturday with her brother, she will remember the order of clothes in which she gets dressed. And we would do things like give a visual support and teach her the order of getting dressed, so that after she goes swimming, she can use some of her self-care support needs. Are they kind of things that are helpful, Nicole? Just type in if that was helpful, or if you'd like some more examples. Yep. And good. As a SC, what's an SC?
I was trying to work out what an SC was as well. I don't.
Support coordinator, I bet you. Yes, okay, I got it. Yep. I just thought of it just then. As a support coordinator, it's vital to help keep communication open with the allied health service. Absolutely. To keep the continuity of services and best outcome for NDIS participants. I can tell you, when I moved to Canberra, the support coordinators that I used to work with, they still contacted me. You know, it is absolutely vital that your support coordinators have a great relationship with your allied health services and part of your care team. Many of our students, I can tell you, probably 60%, 60 to 70% of our students are working as support coordinators while they're studying speech pathology. So trust me, we're working on making sure that they're part of that communication. Yeah.
That's great. All right. I don't think there's any more questions there, CaraJane. Thank you so much for your insight this afternoon. It's been really wonderful to talk to you and to have you at our webinar. So unless there's any other questions, we might sort of just wrap it up there. So there's no other questions in the pod. So there will be a participant evaluation survey. I think that's going to appear on the screen as well, if we can get that up there. So if we can take some time to fill out that, if you can, to let us know sort of what's been going on. I'd really like to thank Rhys Adams, our first presenter, and also CaraJane for their participation today and their time. It's been really fantastic. I'd like to thank Nicole and Kerry from the Spider Project, and also Jane Buller, the Workforce Development Officer from the West Vic PHN, for their hard work on these webinar series, and look forward to seeing people at the next series. So thank you very much.